Bismillahirrahmanirrahim. I'd like to thank Professor Muhammad Fadel for giving me this opportunity to participate in this congress, and I also want to apologize for not attending it live because I am now performing my AO fellowship trauma in Tübingen. My talk today is about pediatric bone and joint infections and how it differs from adult. As we all know, in a child less than 1 year, the blood supply crosses the physis, so spread of infection could occur from the metaphyseal area into intra-articular physis. Later on, the physis acts as a barrier for spread of infection, but the acutely bent blood supply make it vulnerable to infection due to blood stasis if hematoma formation occurred. And later on, after skater maturity, the blood supply is continuous from the shaft to the end of the bone. Septic arthritis can develop from spread of pus from intra-articular metaphyses like hip, shoulder, elbow, and ankle, but not the knee because its metaphysis is completely extra-articular. Usually, osteomyelitis start with hematogenous spread due to Staph aureus infection. Direct inoculation could happen due to penetrating injury, open fracture, and surgical contamination. And immunocompromised children are more vulnerable to develop osteomyelitis and septic arthritis. In acute osteomyelitis, it starts with usually after hematoma formation, infection with the organism, and pus formation finds its way through a sinus to form subosteal abscess, and later on the sequestrated dead bone is separated from the original bone, and during development into chronic osteomyelitis, the envelogram is formed to act as an envelope to the sequestrated bone. Sometimes in the subacute stage, Brody's abscess is formed where the constitutional symptoms subsides and pain is occasional. Clinical picture of pain and limping and constitutional symptoms like fever and toxemia, hotness, redness, and edema, and restriction of joint of motion. It's important to take care in deep joint like hip and shoulder, where the thick muscle covering the joint mask the hotness, redness, and edema. And children who are neonates and preterm, especially admitted in the neonatal ICU, should be very suspicious of hip or shoulder arthritis. Radiology usually plain X-ray is normal in early infection, and radiological investigation starts later on. MRI has the upper hand of being highly sensitive in detection of early infection, especially with gadolinium contrast. Ultrasound for the hip or the shoulder plays an important role to detection of effusion and aspiration guided ultrasound. Laboratory investigation like leukocytosis, raised ECR reactive protein, and blood culture. It's important to put in mind the differential diagnosis of non-infectious arthritis like transient synovitis and inflammatory arthritis. Treatment is a combination of antibiotic therapy according to culture and sensitivity, surgical debridement, and management of complications like septic arthritis, dislocation, cross disturbance and lip length discrepancy, and pathological fractures. This is a case of left septic hip, and later on, after debridement and drainage, it resulted in a persist-like lesion with coxa previa and coxa plana and fragmentation of the head. This case of Brody's abscess at the infromedial part of the neck, which necessitates drainage through medial Ludlow approach. This case of post-septic knee with destruction of the lateral femoral condyle. And in this case, there is progressive valgus because the lateral condyle is not present due to infection, and correction of deformity alone will result in recurrence of the deformity. So this patient was done by free epiphyseal transfer of proximal fibula, which resembles the original lateral femoral condyle, and after complete union of the transferred epiphysis, correction of the deformity by osteotomy, and putting it below to the medial side to prevent recurrence of the valgus deformity. This case of congenital insensitivity to pain with pseudarthrosis in the femur and left proximal tibia, which simulates the Charcot joint arthropathy. It's important when the child reaches the chronic osteomyelitis and after drainage of subarachnoid abscess, not remove the sequestrum unless a good involucrum is present, because this may result in a bone defect and sometimes it's difficult to be handled. This is a case of osteomyelitis distal femur and drainage only, weight to the involucrum, and bone remodeling occurred, and nearly normal femur with full range of hip and knee after good drainage and waiting for the involucrum to be formed. When septic arthritis occurs and the micromotion, which is painful and stiff, hip fusion is the only solution after eradication of infection. When it's no risk for infection, we can put a contoured plate like this, and if infection is present, we can fix by wires. Like this case, when right hip was fused after deployment and put in wires, and this after 1 year of the operation. The take-home message is to take care of the neonates who are especially preterm and admitted in the neonatal ICU. Take care of the object joint like shoulder or hip, where the constitutional symptoms like hotness, redness, and edema are maybe masked. Deal with complication like gross disturbance, limbless discrepancy. Do not remove the sequestrated bone in the chronic osteomyelitis till good involucrum is present. Hip fusion could be the salvage procedure to compensate the painful arthritic hip. And thank you.